I'm not hearing anything.
I'd like to introduce Dr. Ratnanathan. Do you hear the audio? Okay, and Dr. Ratnanathan will introduce Dr. Shearer.
Okay, I got it now. Okay. I'm sorry about that. Good afternoon. My name is Dr. Ratnanathan. I'm an associate research professor of biomedical engineering at Johns Hopkins, and I'm privileged and honored to be moderating this keynote session by Dr. Eliot, Shearer, Ph.D, professor of pediatric otolaryngology, a member of the Cochrane Plan program at Boston University Children's Hospital. He's the PI of the Translational Genomics Lab. The lab studies genetics of hearing loss, other ear, nose, ENT disorder. He's internationally recognized for his work in developing a new genetic testing platform for the diagnosis of hearing loss, and has written many research articles and several book chapters on the subject. But before I have some housekeeping announcement. If you want CEU credit, be sure to stay for the entire session and be sure to complete the assessment of learning on the CEU grid for this session. And okay, I think the session is going to be recorded. And it'll be recorded session will be available for registered attendee for 3 weeks following the symposium. Attendee can chat with other attendees on the web, or post specific question on the slide or deck. And then okay, so without further ado, Dr. Shearer.
Thank you. Thanks for the introduction, and I'm really excited to be here today. I've heard a lot about AG Bell, and I've never had the opportunity to present or attend the conference before. So thank you for the invitation, and thanks for listening today. So I want to talk about a huge paradigm shift that's been happening over the past 10 or 15 years or so during the course of training and the early part of my career now, where I think the way we view hearing loss and individuals who have hearing loss has completely changed. And this is all really due to the advances in genomics that we've had. So I want to start by thinking about something where in medicine, we have a symptom, we come up with a diagnosis, and then we come up with a treatment based on that diagnosis. Otolaryngology and otolaryngologists like myself, we sometimes circumvent or go around this normal progression. So let me explain what I mean. So if we see an individual in the emergency room and they have chest pain, then we wouldn't automatically take them to the cath lab and do a balloon angioplasty or a coronary artery procedure. We'd need to first come up with a diagnosis. And it's been a long time since I was a medical student and an intern in the emergency room, but I do remember some things that you do to come up with the diagnosis are, take a history, physical exam, vitals, labs, and you'll get an EKG in order to know that this is really a heart attack that they're having, because otherwise you could recommend that they go for a coronary catheterization when really all they have is acid reflux, and all they really need is some omeprazole. So I'm a cochlear implant surgeon and a pediatric otolaryngologist, and I'll often see an individual that has a symptom of hearing loss, and their audiogram may look like this, where they have essentially normal hearing in the low frequencies and then a profound hearing loss in the high frequency. And for decades, we've been taking these patients to the operating room and performing a cochlear implant for them. And this is without having a diagnosis. What I hope that I can explain to you today is that how we think about patients who have hearing loss and individuals with hearing loss needs to shift so that we focus more on the diagnosis. Because if I told you that this patient had a hearing loss due to MyH14, this is a gene that causes a stable form of hearing loss, so it shouldn't change much over time. Maybe I should have more of a discussion about a hearing aid with them, because there are some risks to cochlear implantation. However, if I diagnose them with the gene ACTG1, this is a more rapidly progressive form of hearing loss, and I may recommend earlier cochlear implantation for them. Now, the same audiogram could be someone that has CMV or cytomegalovirus hearing loss. And if this is a very young baby, we would be recommending treatment with valganciclovir, which can stabilize or sometimes even reverse the hearing loss. This is an oral medication that babies are taking now. And this same configuration of hearing loss, they could have a cause or diagnosis of otofurlin hearing loss. I'm going to talk more about it later, but there are now clinical trials starting for gene therapy for otofurlin hearing loss. And so what I would argue is that until you have a diagnosis, you're not able to effectively counsel the patient when you see them in clinic. And this revolution now has occurred where we're able to come up with a diagnosis more often than not. So this is because over the past 10 or 15 years, we've had all these new technologies that improve our diagnostic ability. So one of these is high resolution imaging with a CT, or as shown here, an MRI. The blue arrow shows the cochlear nerve that's normal, and the white arrow shows an absent cochlear nerve on one side. We also are much more likely to perform CMV testing. And so we're able to come up with the diagnosis much more often in children with congenital cytomegalovirus. And then my talk today is going to be focused on genetic testing, and I'll explain how important that is to evaluation of hearing loss, especially children with hearing loss. And there's also really new exciting things like electrocochleography. This is something that we do in the operating room right now. I actually did this yesterday in the operating room. That gives us a really good idea physiologically of what's happening to the cochlea. And so we can understand the physiology of the cochlea at a very precise level. And I think this will be further advancing over the next few years. So all these technologies have combined over the past 10 years or so to mean that in the majority of kids that I see in my hearing loss clinic, I am able to come up with a diagnosis for. So this is one really nice study from Korea, and it shows that for 119 children with severe to profound hearing loss, if you obtain genetic testing, CMV testing, and MRI, you come up with a diagnosis in about 75% of them. So the majority of children now we have a diagnosis for, and this really changes their prognosis. What it also means is instead of thinking about hearing loss as defining for the person, instead, I'd like to change how we think about this symptom. And it allows us to think about the deaf or hard of hearing person first. And then their diagnosis could be one of hundreds of different things, okay? There's many things that could cause hearing loss. So things like CMV, like I told you about, or cochlear nerve hypoplasia. But also aminoglycosides or certain drugs can cause ototoxic hearing loss. And then some genes like otofurlin or stereocillin. This diagnosis really is what leads to the reduced hearing. And by understanding the diagnosis, we're able to personalize care. So this could mean something like hearing aids, like I talked about, cochlear implants, auditory brainstem implants, valganciclovir for CMV hearing loss, and gene therapy. All of these options are now on the table, much different than 15, 20 years ago. And so I would argue that you really need a good understanding of the diagnosis so that you can best treat the individual. I would also bring up, and I'm just a realist about this, there's some individuals where none of these options are going to be the best treatment option, either because they don't work effectively or because of choice. And so we also have to remember, even though I'm talking to AG Bell, I would remind everyone about ASL, which some of our patients choose to use. So as an overview, I'm going to talk about genetic testing, and we're going to talk about sort of a who, what, where, why, how. for genetic testing. And then I'm going to talk about some really exciting future directions. While I'm talking through this, I'm going to bring up four patients that I think really demonstrate how important genetics are and a diagnosis is for these individuals. So this includes everyone from a 7-month-old all the way up to an 18-year-old, okay? So what is genetic testing for hearing loss? Well, going back to thinking about all the causes of hearing loss, we think that about 65% of all childhood hearing loss or congenital hearing loss is due to a genetic cause. This varies based on country and based on the ethnicity and exposures, but 65% or about 2/3 is genetic. Another 10% is an anatomic difference in the cochlea, the vestibule, or the auditory nerve. And a good proportion is congenital CMV. I'll focus more on genetics in a minute, but I want to take a step back because I know maybe not all of you think about genetics as much as I do. Just to give you a broad overview, about all humans have 23 pairs of chromosomes, right? So we have the 22 autosomes and then 2 sex chromosomes. And we have about 20,000 genes in our genome. That means that each of us has about 3 billion base pairs of DNA, and this is the code that encodes for how our cells function and then how our body functions. Each of us has 2 copies of every gene, one from mom and one from dad. And each of us has about 20,000 changes that are different from us to our parents. And this is why this is natural variation, natural change that occurs with generations, and it's why we're not clones of our parents, okay? So if you look specifically at the genetics of hearing loss, as I told you, about 20% is environmental. The vast majority is congenital CMV. And in the US, genetic causes are about 80%. In developing countries, it's more about 50%, and environmental causes are more common. When you look at genetic causes, about 30% are syndromic forms of hearing loss. So a syndrome is hearing loss plus anything else, any other clinical feature. So the most common are listed here, like Usher syndrome, which is hearing loss and vision loss, Pender syndrome, which is hearing loss and thyroid problems. There's actually several hundred syndromic forms of hearing loss, but these are just the most common. But the majority of genetic hearing loss is non-syndromic, so there's only the hearing loss. And this can be inherited in all different forms. The vast majority of the time, inheritance is recessive, which means both parents will have normal hearing. Hearing loss is extremely genetically heterogeneous. So what I mean by that is there's 124 total non-syndromic hearing loss genes. And this has made studying and testing for genetic hearing loss so difficult. It also makes it really interesting to study, but it's such a complicated system. There's so many different genes involved. This is in comparison to things like cystic fibrosis, where there's one single gene that's involved. So this is data from a publication we did a few years ago, just showing more than 2,000 deaf and hard of hearing individuals. And we looked at all the genes that cause hearing loss in them. You can see that no single gene formed the majority. In fact, it's extremely complicated. There's dozens and dozens of genes. This one gene called GJB2 or connexin is the most common, but really there's no one gene that forms the majority. And so this makes genetic testing very complicated. So the answer to this is something called comprehensive genetic testing using massively parallel sequencing. And that's a mouthful, but I'll explain what I mean by that. So if you go back in time, I know people who are younger probably don't remember when computers looked like this, but these are the computers and the DNA sequencers that were used to complete the Human Genome Project in the year 2003. This method of DNA sequencing is called chain termination sequencing, and it costs about $8,000 per million base pairs to do. And I told you each genome has 3 billion base pairs. So this took years to sequence one human genome. So in about 2008 to 2010, new technology came around called massively parallel sequencing. And this is what these sequencers look like. Essentially, they sequence the human genome at a massively parallel scale. So each of these dots is part of the human genome being sequenced with fluorescence. And the cost is dramatically lower, so less than $1 per million base pairs. And you can sequence several human genomes within 24 hours. So now in my lab, I have this handheld sequencer that for a few $100s is able to sequence DNA by pulling a single DNA molecule through a pore. And so it's just been incredible, and it's hard to overstate how big of a change this has been over the past 10 or 15 years. But what we realized in the early 2000s is that this technology could be groundbreaking and very important for the evaluation of genetic hearing loss. And so in 2010, we published the first article using this new technology for evaluation of hearing loss. We did this for 6 patients because it was still very expensive at that time, and 10 total individuals. And we found very quickly that it was a very effective way to provide a diagnosis to families. Because of this, it was quickly followed by many other papers, and I'm only showing a few of them here. One of my favorites is a few years after we had published that we could do 1,119 patients, and then very quickly after, a group from Japan did 1,120 patients just to show they were a little better than us. But the point is, this technology totally revolutionized how we evaluate hearing loss, and it's been used in hundreds of studies and thousands of patients. And it really has become the standard of care for evaluation of hearing loss, and has allowed us to learn so much more than we ever knew before. So this is the platform that I worked to develop. This is otoscope testing, but there's many different genetic testing companies in the US and worldwide that offer similar testing. What we call this testing is comprehensive, which means it tests all the hearing loss genes at once. And it uses these new sequencing techniques, and almost all of them sequence for all the non-syndromic hearing loss genes, and then many of the syndromic hearing loss genes at the same time. And I'll tell you why that's so important in a minute. So why do we perform genetic testing for hearing loss? Well, the easiest answer is it's the single most effective test. So what I mean by that is almost every study now has shown that genetic testing comes out, if you look at all individuals who are undergoing genetic testing with hearing loss, we figure out a diagnosis in 40% of them. And that's been remarkably solid over the past 10 years. If you get a CT on those same individuals, or you get an MRI, the diagnostic yield is lower. Even when I was starting training, we would talk about doing all sorts of other tests. So like a thyroid ultrasound or blood work, anything like that. The yield of those tests is very low. And so it really is the single most effective test for evaluating hearing loss. Most importantly, a genetic diagnosis provides important information for families. So I'm going to talk about this a little bit more, but it provides prognostic information. So whether the hearing loss will stay the same or get worse over time. It provides information on recurrence risk. So I told you that most of the time, parents will have normal hearing. And so it can provide information on if they have another child, what the chances are that they would have hearing loss, or when their child goes on to have children, what the chances are. And then we've been finding more and more that syndromic hearing loss is probably more common than we thought. So we see, and others see, that about 20% of the diagnoses that we give now for young children is syndromic forms of hearing loss. So again, things like Usher syndrome, which is hearing loss and blindness. And this is hugely important to families. I would argue overall, probably the most important thing about a genetic diagnosis is it empowers patients. So instead of having a symptom, the patient will have, and the family will have, an underlying diagnosis. So as an example of this, one of my patients' families, they started this stereocylin STRC gene mutation hearing loss group on Facebook. And this is so important for patients because they're able to share stories about best treatment options and prognosis, and it provides a sense of identity that in the hearing loss field we haven't had before, because there's literally hundreds of different forms of hearing loss. So some of you may be thinking that the genetic testing rate or diagnostic yield is only about 40%. Well, I was talking to one of my colleagues in neurology, and she was saying, that's great. I can't believe you can get 40% diagnostic yield. And I started looking into it, and I looked at some neurologic conditions and other conditions that we routinely order genetic testing for. So things like autism. Part of the standard workup for autism now is genetic evaluation. The overall yield for that is only about 17%. Essentially, any child with epilepsy, that seizure disorder, will get a genetic workup now. Again, that diagnostic yield is only about 25%. Same for intellectual disability, it's less than 30%. And now a new advancement in the NICU, the neonatal intensive care unit, is we'll do genetic evaluation, sometimes at very high expense, and we do a turnaround time in less than a week to come up with the diagnosis. This is very expensive for the healthcare system. The diagnostic yield is 36%. So overall, if you look at our diagnostic yield, it's really very good. And so I would argue that we're actually doing a really pretty good job. I would also say this means that anyone who's involved with hearing loss or caring for patients and families that have hearing loss, all of you are geneticists, whether you like it or not. So you've got to learn some genetics, because almost half your patients are going to have a genetic disorder when it comes down to it. So I want to take a second here and talk about this first patient. So this is a 7-month-old with severe to profound hearing loss bilaterally. This child referred on the newborn hearing screen on both sides, and the family is they're go-getters, okay? So they've got hearing aids by 3 months of age. So far, for 7 months old, the child has normal developmental milestones. So I'll talk about how I evaluate children with hearing loss at the end. I'll talk about my diagnostic evaluation, but as we typically do, we order genetic testing for this family. You can understand the questions this family wants to know. So what's the cause of the hearing loss? What's the prognosis? Are there any other associated conditions with it? And then if they go on to have another child, what's the recurrence risk? Well, we obtained genetic testing result which showed 2 pathogenic, which means causative variations. Variation is a genetic term for mutation in the gene cadherin23. So this is a diagnosis of Usher syndrome type 1. And I've got to tell you, this is giving these results back to families is essentially the hardest thing that I do in my job. It's really devastating to tell this family that's dealing with a new diagnosis of hearing loss that their child will go on to develop blindness by the time they're in their teenage years, or sometimes sooner. It's really devastating for the family. And what we're finding more and more often is that as an otolaryngologist, as an ear, nose, and throat surgeon, I'm very often the one providing this diagnosis. So even 10 years ago, people would realize their child was having vision loss and then come about the diagnosis much later. Because we're doing genetic testing very early, we are giving this result back very early to families. So far, after an initial period of sort of shock and grief about this, I'll tell you that every family I've worked with is so thankful to have the diagnosis, because they're able to prepare. First of all, it changes what they're thinking about cochlear implants. If they were, thinking about delaying them a little bit or on the fence about it a little bit, when you hear that your child's also going to be going blind, it totally changes your outlook on that. And then they're able to do things like take vitamin A, wear sunglasses, teach your child Braille much earlier. And so universally, people are thankful to have this information, but we're finding this much more common than we realized, and it's a difficult conversation to have. So just overall, looking at prognosis and management, I just wanted to show 2 different genes here. So this is the gene alpha-tectorin, and this is the gene casein Q4. This is audiograms or hearing over time. So you can see from age 0 to 20 all the way up to age 60. This is data from University of Iowa. I helped with this during my medical school and residency and Ph.D. But you can see that the Tech Day hearing loss, alpha tectorin, it stays relatively stable until much later in life. Whereas if you look at KC&Q4, it's pretty steadily progressive over time. And so, as I alluded to before, this really changes your conversation with patients about hearing aids versus cochlear implants. I use this on a daily basis in my clinic. When I see a child that has a stable form of genetic hearing loss, instead of doing a 3 or 6 month follow-up, I can see them every year because I have a diagnosis. So I can be relatively confident that their hearing will not change over time. So it does change my clinical management. So let's talk about another patient. So this is a very different audiogram. This is a child who has primarily sensory, a little bit mixed hearing loss that's more mild. It's much more mild. And this is an 18-year-old that has suffered from what this was identified as a newborn hearing loss. But they also had issues with eustachian tube dysfunction, and they had a lot of ear infections. So they had a bunch of ear tubes placed. They'd kind of been using hearing aids, but only occasionally. And they also had ADHD. Now, this is not someone that we would typically think about as appropriate for genetic testing, but we've been ordering this here at Boston Children's. And the reason we do it is because this 18-year-old has the same question. So they have always wanted to know what the underlying cause of hearing loss is, and they wanted to know going forward what the prognosis would be. We found a pathogenic variant or a causative mutation in the gene FGFR3. And this is Menke syndrome, which is a syndromic form of hearing loss that can cause craniosynostosis, so abnormal fusion of the skull, hearing loss, and then some ADHD and behavioral difficulties. When we talked to the patient, she always had a large head size and occasionally misshapen head ever since she was born. And she, as I talked to you about, she had ADHD. And this was hugely impactful for this child or this 18-year-old to have this diagnosis. When I saw them back after we gave this genetic testing result, they were wearing their hearing aids consistently. It was almost like they had never quite believed that they had an underlying hearing loss. And now we had a diagnosis for them, and they were on board for it. So it really changed how they thought about their symptom. I'll also say that we're understanding that these syndromes are on a spectrum. So when the person first described this many years ago, they described a very severe clinical features. What we're finding as we do more genetic testing is there's a spectrum. So there's more mild and then there's more severe. And unless you test individuals that have more mild clinical features, then you're not going to find them. And so this is the perfect example of that. So other reasons why to perform genetic testing. Well, there's consensus guidelines now. This is from the International Pediatric Otolaryngology Working Group, and then also the American College of Medical Genetics and Genomics. And they both recommend that genetic testing should be part of the standard evaluation for children with sensory neural hearing loss. Another reason is cochlear implant outcomes. So I'm a cochlear implant surgeon. In the vast majority of cases, I tell patients that cochlear implants are the effective treatment for severe to profound hearing loss. And you'll see a lot of data that looks like this. So this is 2 different word understanding scores, CNC and AZ-Bio. And this is many patients. And what we tell the patients is they get above a 70% word understanding in the majority of cases, or on average. But when you drill down and look more closely at this data, what you see is it looks a little more fuzzy. So you can see many patients did fantastic, but there's some that did not do as well with the cochlear implant. And this is a difficult topic for cochlear implant surgeons and physicians to talk about. I understand that. At the same time, I want what's best for my patients. And so I'd like to best be able to tell them how they're going to do with a cochlear implant. What I would ask is, can we improve these outcomes in our understanding of cochlear implant outcomes with a better understanding of genetics? The problem is that cochlear implant outcomes is very complicated. So there's a lot of factors that go into this. So there's things like the environment. So there's been a lot written about the socioeconomic status of patients, their time without hearing or duration of deafness is probably the biggest overall single predictor for cochlear implant outcomes. But there's things like social interaction. So how many spoken words they're exposed to. That's very important. There's also clinical variables that influence cochlear implant outcomes. So what device, what surgeon, if they had any complications, how the training was going, how the activation went. I would argue that genes are also involved in this too. So, the sensory pathway, how the brain processes the sound. So I think that a better understanding of cochlear implant genetics would allow identification of poor performers preoperatively. So I would like to counsel a patient and a family, you are at risk for poor outcomes. So we need to really make sure that we do extra training for you, or you really understand the risks going into this cochlear implant. I want to be able to tell them that before surgery. And so then we could focus activation and training and follow-up for at-risk patients. And ultimately, this will pave the way to precision-tailored cochlear implants that are focused specifically on at-risk patients or specific genes. So one way to think about this, and this is not my idea, other people have thought about this too. If you think about the hearing pathway, you have the hair cell, you have the nerve, and then you have the brain. And the cochlear implant electrode bypasses the hair cell in the inner ear that doesn't function properly. And so the hypothesis is, or the idea is, that individuals that have a problem with the hair cell will have a good outcome with the cochlear implant, whereas those that have a problem with the nerve may have a worse outcome. So I've studied this and other people have studied this, and results so far are, to put it frankly, mixed, and we need more information. There are some genes that are associated with worse outcomes than others, and generally this holds true. So as an example of this, I want to talk about another patient. So this is a 16-year-old that has had a progressive high-frequency hearing loss. Her word understanding has been decreasing significantly over time. So it's decreased to the point where they are now a cochlear implant candidate. They really want to know what the cause of the hearing loss is and whether a cochlear implant's the best treatment, because overall they've been doing great with hearing aids, even though their word understanding is poor. We identified pathogenic variants in the gene TMPRSS3, which it gives a diagnosis of non-syndromic hearing loss for this individual. So this is really complicated because there's very mixed data if you look into the literature about these individuals that have TMPRSS3 hearing loss. It's a common cause of hearing loss in adults that have cochlear implants, which I'll show you later. Some studies have shown that these individuals do worse with cochlear implants. Some show they're done better. We need to do a lot more work to better understand this. But what I did in this case is I counseled this family about the controversy. I did say, however, that cochlear implants are still the most effective available treatment for severe to profound hearing loss. So I would say there's a lot more work that needs to be done to understand the genetics of cochlear implants. The next part about reason why we get genetic testing is gene therapy for hearing loss. So many of you may have heard about how this is now happening. And I want to just take a second to explain a little bit just sort of the basics of gene therapy. So the basis is, first you have to understand the molecular mechanism for hearing loss. So you have to have a diagnosis first. So in this example, this is the organ of Corti in the inner ear. This is the hair cell, and we'll just hypothetically say that this inner hair cell here lacks a protein, so there's no hearing, or there's a hearing loss. What you then need to do is choose a viral vector, so a virus, that will carry the gene. Most of the time we use adeno-associated viruses because they're very effective. And then you have to choose a surgical approach to inject the inner ear. So there's many different ways to do this. This is a very broad general overview about gene therapy for hearing loss. Just like the rest of hearing loss, though, it's much more complicated. So there's many different methods for molecular therapy. So there's replacement of a whole gene. You can stop a gene from being expressed. You could even edit a gene using something called CRISPR, which was the focus of the Nobel Prize just a couple of years ago. And then there's ideas of cell replacement with things like stem cells. Also, really importantly, we need to stop and consider the ethics of doing gene therapy for hearing loss. We also need to think about the efficacy of the therapy, so how well the therapy works, especially when we have something like cochlear implants that work very well in the vast majority of cases. You have to show that this gene therapy is going to work better. You also need to think about and make sure there's no systemic effects, so effects of the virus on the rest of the body and just overall safety. So I have a ton of concerns about gene therapy for hearing loss. It raises a bunch of issues. At the same time, I feel like we need to be, and the field is moving that way, so we need to be able to stay on top of this. I will say that any genetic therapy requires an accurate genetic diagnosis. And so if we're not providing a genetic diagnosis for families, they can't enroll in a clinical trial. And so what I mean by that is there's 2 companies in the US that have now started phase 1, phase 2, which is early clinical trials for otoferlin, OTOF hearing loss. This means that this year, probably, I think, in the next couple months, there's going to be the first human that's going to be injected with a gene therapy for hearing loss. I just a couple of years ago, I thought maybe it would happen within the next 10 years, and now all of a sudden it's happening. So it's very exciting, but at the same time, it gives us a lot to think about. So you can see here they're choosing otoferlin first, but there's other genes down the pipeline. So GJB2, which is the most common, and then stereocylin as well. And I'll talk more about that in a minute. So just very briefly about otoferlin, OTOF gene therapy, because you're going to be hearing more about this on the news. Otoferlin encodes this protein at the base of the inner hair cell that allows this vesicle with the neurotransmitter to synapse. So to actually connect and allows the synapse to function. So what I mean by that is the hair cell is there and the neuron is there. It's just the connection between the two that's missing. And so for that reason, it's been a very, highly targeted therapy, because you have all the structure there. You just need to connect them back together. So this is some data from mice, and in bright green you can see the hair cells that have been transfected with the virus that expresses otoferlin. And here you can see data from mice showing that in the black, this is ABR, or auditory brainstem response. In the wild type mice here, otoferlin here, knockout mice, so they have no otoferlin, have almost no response. And once you inject them with the otoferlin gene therapy, the response comes back dramatically. The other reason that people chose otoferlin is because you can do this in essentially adult mice. So it gives a time window for us to intervene with gene therapy. So those are the reasons that people chose otoferlin as the first clinical trial. I want to talk about another patient, the last patient. So this is a 7-year-old that didn't pass a newborn hearing screen and has this mild to moderate form of hearing loss and is otherwise healthy and wears hearing aids. This family really wanted to know, and they actually asked me whether there was a gene therapy for their child's condition. Well, we got genetic testing, and we identified a deletion in the gene stereocylin as the cause of their hearing loss, STRC. This is far and away the most common cause of mild to moderate hearing loss. It's very difficult to test for because of the gene, complicated reasons I won't get into. And so people 10 years ago weren't looking for it. Now we found it's very, very common. It's second most common gene besides GJB2. Jeffrey Holt, who I work closely with here at Boston Children's, his lab group recently published a really incredible article and using gene therapy to restore hearing in mice that had stereocylin hearing loss. So this is the dramatic photo showing the little projection or stereocilia off the hair cells. This one here is lacking stereocylin, and this one here has the stereocylin gene therapy. You can see how nice and straight those hair cells are. So in my practice here in Boston, and I don't know if this is like this in the rest of the country, essentially on a daily basis, when I see children with hearing loss, families are asking whether there's a gene therapy. Some people would argue that a child who wears hearing aids shouldn't use a gene therapy. I would say that some of these families who, and many of you have done this, but if you take a 3-year-old boy and you try to put hearing aids on them, or a 2-year-old boy, it can be very difficult, and the hearing aids end up hitting the wall because they're throwing them off all the time. Some of these families, if you could tell them you can do 1 injection in the inner ear and then they would never have to wear hearing aids again, they would sign up in a heartbeat. So I would argue that actually children with hearing loss that is mild to moderate, they should also be considered as candidates for gene therapy for hearing loss. It doesn't necessarily have to be just cochlear implant candidates. And in some respects, maybe the children with hearing aids are better candidates because cochlear implants work very well for a lot of people with severe to profound hearing loss. So this is clearly where things are moving. And I told you some of the companies are looking at doing this trial in humans in the next couple of years, I think. So who do we perform genetic testing for hearing loss? Well, the diagnostic rate does vary by clinical characteristics. So I told you that overall, the diagnostic rate or diagnostic yield is about 40%. So we identify a diagnosis in 40%. But it's higher if you have a family history of hearing loss, or if it's earlier, so congenital hearing loss is the highest diagnostic yield. And if it's a symmetric hearing loss, so if it's bilateral, we're able to come up with the cause more frequently than asymmetric or unilateral. But if I see a baby that has congenital, profound, bilateral sensorineural hearing loss in a normal physical exam, I tell them we have about a 60% chance of figuring out with 1 test, with a genetic test. And that's hugely impactful for these families. We do know the genetic diagnosis varies by age. So this is one study we did that looked at cochlear implant patients. And so in pediatric cochlear implant patients, 100 of them, we came up with the genetic cause in 50%. The most common was GJB2. When we looked at 359 adult cochlear implant patients, we came up with a diagnosis in only about 22%. And you can see the genes are very different. So that gene TMPRSS3 is the most common. And you can see for adults with cochlear implants, the other genes, there's almost no overlapping. So it's very different between adults and children. We also know the genetic diagnosis varies by race and ethnicity. So if you look at Caucasian individuals, you can see that GJB2 is the most common, followed by stereocylin. But if you look in Hispanics or African Americans, GJB2 really is not a major contributor to genetic hearing loss, especially in African Americans. And what Dylan Chan at UCSF has done a fantastic job showing the impact of race and ethnicity on genetic diagnosis for hearing loss. And what they've shown is that for children who are Hispanic or Black, the chance of coming up with a genetic diagnosis was 5 times lower. And so this is a really important area of work for us to be doing. We need to focus on how to improve the equitable genetic diagnosis for children with hearing loss. And my lab's working on this, and as are others too. So here's how I approach evaluation for a child with hearing loss that comes to my clinic. I perform a history, physical exam, and audiometric testing. If they're less than 3 weeks old, we obtain CMV testing for congenital cytomegalovirus. This is a cheek swab. If they're older than 3 weeks, then they may be exposed to this in the environment, so we won't do this automatically necessarily. If they have specific physical exam findings, and this is pretty rare, so this is things that I can identify based on physical exam of the baby, then we should obtain genetic testing based on what syndrome I think it is. But I've got to tell you, a lot of really young babies, they look very similar. They're all generally very, very cute. So it's hard to tell them a syndromic diagnosis in a young baby. So the majority of kids have apparent non-syndromic hearing loss. And if it's bilateral, including asymmetric, we do all 4 of these things at once. So we get genetic testing. We send them to see an eye doctor, which could take a few months. And we do this because they may be more reliant on visual stimuli. We get an EKG because it's cheap and non-invasive. And it can evaluate for something called Jervell-Lang-Nielsen syndrome, which is a long QT syndrome. It can cause sudden cardiac death in children that have severe to profound hearing loss. So we obtain that for these children. And then we typically get imaging. At our institution, I'm very lucky to be at a place where we're able to do a non-sedated MRI. So we do a feed and wrap protocol where we bring the baby in hungry, and then we wrap them up and have them sleep during the MRI. And we have almost a 90% success rate on that for kids less than 6 or 8 months of age. And that's, so typically we get these MRIs on children that are very young. And the genetic testing right now takes about 3 months. If it's a unilateral hearing loss, then we'll typically get imaging first based on our prior studies. But I will tell you that we have a large study here at Boston Children's looking at genetic testing for asymmetric hearing loss. And if you look, so when we look at children that have symmetric hearing loss, I told you our diagnostic rate's about 40%, just like other studies have shown. Our asymmetric diagnostic rate is about 23%, and our unilateral hearing loss diagnostic rate is about 18%. What I will say, though, is if you look at the syndromic diagnoses, so the number of children that had a syndrome is about 20% for bilateral hearing loss, 33% for asymmetric. And in the children with unilateral hearing loss, we diagnose the syndrome in more than half of cases. So some people would argue that maybe it's actually even more important that we obtain genetic testing and come up with a diagnosis in children with unilateral hearing loss. So now I'm starting to change how I think about this, and we routinely talk about genetic testing for unilateral hearing loss in children. So how do we obtain genetic testing for hearing loss? I told you about these different companies. It's very expensive, $1,000 to $4,000, and it takes 1 to 3 months right now. Again, I'm lucky to be at an institution where we do prior authorization within our institution to test for this. But I will say, based on studies that I've done and other people have done, we've convinced insurance companies that this is important. And so when we looked at our last 100 patients, in 2/3 of them, insurance actually covered the genetic testing completely. 80% of private insurers covered, and then 50% of the time in Massachusetts, our state public insurance covered. So this is, again, a huge shift from 10 years ago when essentially genetic testing was never covered. I'm happy to say that genetic testing is now recognized by insurance companies as important. And some states like California, for public health insurance, they always cover it no matter what. So there's been a big change. So now just a couple minutes on future directions. So we need to find what I think of as the therapeutic window. So if you think about something like a cochlear implant, we know that over time there's decreasing efficacy, or it works less well over time. Maybe a graph something like this. This is probably due to a decrease in the spiral ganglion neurons or the brain, and also the brain kind of reshaping how it uses the information that it's given. And also, if you think about single-sided hearing, there's a side preference that develops over time. So essentially, you start to ignore the side of the side of your brain that doesn't receive sound. What I'll tell you is that our average age of genetic diagnosis at Boston Children's, even though we have all the resources in the world, is about a year of age. And so this gives our therapeutic window somewhere around here. What we'd really like to do is decrease or move the therapeutic window earlier. And the way to do that is with newborn hearing screening. So I don't have to explain to you all how the importance of newborn hearing screening or go over it too much. But in 1994, the Joint Committee on Infant Hearing endorsed universal newborn hearing screening based on a lot of data showing that earlier diagnosis of hearing loss improved outcomes. And then by 2000 in the US, universal newborn hearing screening was developed. And by 2010, 98% of newborns undergo newborn hearing screening. And so we've dramatically increased the number of babies that we identify with hearing loss in the US. But if you look at all of newborn screening, so not just newborn hearing screening, it's pretty remarkable. So this is all these different disorders that are screened with newborn screening. So there's things like galactosemia and propionic acidemia and sickle cell disease and cystic fibrosis. Those are the more common ones. Hearing loss is far and away the most common identified disorder on newborn screening. And another way to look at that is 50% of the disorders identified on newborn screening are hearing loss. And so it's really important for us to think about ways that we can improve newborn screening. It really is a primary condition that's identified during newborn screening. So if you think about the current standard of care, what we currently do, all newborns get physiologic screening. If they fail that, then we get genetic testing or congenital CMV testing. What I'm proposing, and other people have proposed too, is rapid comprehensive screening, where if an individual fails their physiologic screen from the dried blood spot, we obtain genetic screening and CMV immediately. And this would decrease our time to diagnosis and extend our therapeutic window to earlier, so we can earlier apply cochlear implants, hearing aids, gene therapy. Our goal is to do this by 3 months of age. And I don't have more time to talk about that today, but I'm really interested in improving the newborn hearing screening. So just to give you an idea of the future of where things are going, I'm so lucky to be at Boston Children's Hospital with the group that I have. This is a pipeline that we have in place right now. So this is what we're doing right now. We see a patient with hearing loss. We obtain a genetic diagnosis for them. I work with Marley Kinney, who's a brilliant clinician, and we identify the molecular mechanism. Using CRISPR, within months, we can develop an animal model for that form of hearing loss. I work with Jeff Holt and Gwen Gilliac. They're experts on gene therapy. They can very quickly develop a novel therapy and test that therapy on the mice. And then really amazingly, I work with Carl Kohler, who actually takes the patient's stem cells and turns them into the inner ear and grows it in a petri dish. And we're able to test gene therapy on the patient's own cells in a petri dish, and then we're able to apply that to the patient. So this is all happening right now, and it's just really incredible and really exciting to be part of it. But the take-home points are that hearing loss is a symptom. It's not a diagnosis. And a diagnosis for hearing loss provides the patient and the clinician with valuable information. And it really does guide the management of hearing loss. And whether we like it or not, gene therapy for hearing loss is here, and it's going to be affecting all of us and our patients. Hopefully, I've shown you that instead of thinking about hearing loss like this as a symptom, we can learn to think about the patient first and think about the diagnosis first. So with that, I'd like to thank everybody in my lab. I'd like to thank A.G. Bell for having me. Really appreciate it, and happy to take any questions.
Thank you very much, Dr. Shearer. A fantastic talk. I mean, I learned a lot. There are several questions. I hope we can cover them in 7 minutes. I'll take the most obvious one. Do you have any data on possible cause for the cookie bite losses?
Yeah, there's several genes that are very well known to cause cookie bite hearing loss.
And the genetic diagnosis or material at the time developed related to the age thing, but I think that case developing over time. The genetic diagnosis materialized over age.
So most genetic forms of hearing loss are something that you're born with. It's your genes that you're born with, and then you may develop hearing loss over time, or it could be congenital or from birth. I kind of went over it kind of quickly, but the diagnostic yield for adults with hearing loss is about 20-25%, whereas for children, it's more like 50-60%. The reason for that is just we don't understand adult onset hearing loss as well. If you were born with a hearing loss and then it progressed over time, we can figure out a genetic diagnosis in a lot of cases. But there's a lot more work to be done for adult onset hearing loss. But that doesn't mean that we shouldn't be doing it.
What is the process of the otoscope genetic testing? Do the patient consult with the audiology team, and also to health insurance cover this? And also, what is the anticipated out-of-pocket cost with it? Yeah,
so at least in Massachusetts, in my practice, I went over that about 2/3 of the time it's covered by insurance. It's a test that needs to be ordered by a physician. So no matter what, at least in the US. So no matter what genetic testing company you use, in the US, it needs to be ordered by a physician. Most of the time now, it's just a cheek swab, so it doesn't have to be a blood draw, and that can be sent into the lab. If it's covered by insurance, as it is the majority of the time in the US, there's the only out-of-pocket cost would be the copay or any out-of-pocket costs that you have with your insurance company.
Okay, then so many questions I'll try to get with them. I have one question from me. Have you been able to relate MRI scan with genetic data and combine them together to get a better sensitivity?
Yeah, that's a great question. So we've found that with unilateral hearing loss, there may be children that have a cochlear nerve hypoplasia or cochlear nerve size difference. And we've found syndromic hearing loss in several of those patients. And so, yeah, in some cases, we do have a genetic diagnosis and an MRI finding.
There was a question, why are 60% of the cases in genetic testing could not come up with their diagnosis? Either that number will reduce when technology improves.
Yeah, that's a great question. First of all, as I talked about, I think our diagnostic yield for hearing loss is very good, but me and many other people are still working on ways to improve that. I think we're still missing things because we need new sequencing technology. So something I didn't have time to talk about is there's even newer technology that looks at the whole genome in a different way. It's called long read genome sequencing. And we have some individuals that we've come up with the diagnosis that way that has been negative other ways. So I do think that we need new technology still, and we need more testing to figure out the cause. But I think within the next few years, that diagnostic yield rate will go up even higher.
And one question, in your team working with the patient and the family, do you have a listening and spoken language specialist involved in the process and share the typical needs and results? And is there a benefit in having an audio or speech language pathologist working with the family?
Oh yeah, absolutely. We at Boston Children's, we have a I'm very lucky to be part of a team. We always take a team-based approach to evaluating and working with families that have hearing loss. So I'm part of the deaf and hard of hearing program at Boston Children's. So there's audiologists, speech pathologists, neuropsychologists, social workers. So there's a whole host of support. I definitely don't do this alone.
I've got 2 minutes left. I have one more question. After it comes with the UK, what might account for the difference in rate of genetic diagnosis with children and adults, presumably demographic, with rate with balance?
Yeah, again, that's a great question. I think part of it might be things like epigenetic changes. So this is changes that can occur to the proteins that surround the genome. And those are very hard to find for us still. And then some of it's probably just a combination of genes and environment. So we may be predisposed to hearing loss, and then with repeated noise trauma that can lead to a more severe hearing loss. And so it's harder to study in adults, I would say.
Well, okay, I think there's so many questions, but I think I have to make an announcement before we close in 2 minutes. I'd like to remind everybody, if you want to see your credit, be sure don't forget to complete the assessment of learning and the CEDU group discussion. And so I'd like to thank Dr. Eliot here for a fantastic talk and completely educational, not for me and everybody else. And so thank you very much.
Thank you very much for having me. And I'll just let everyone know that I'm happy to make my slides available as handouts afterwards.
That would be great. We've had some people ask, of course. That would be great. Thank you.
No problem.
Oh, that was terrific. So enjoyed it.
Thank you.
Happening.